Let me just give you an overview of payment. I think this is helpful to put into context the terms that we've been kind of bandying about for months now, the categories of payment that we have been referring to and how they fit together. And then after we provide this overview, we're going to turn to Brant and Mary for a specific sort of tutorial on case mix in particular. So last time we talked about design principles. For example, that clients must make setting of care choices with full knowledge of their eligibility and assessed level of need. So universal assessment addresses that over time to have real-time administration of the universal assessment, helping us with both eligibility and levels of care. Secondly, clients should receive services and funding appropriate to their needs. Again, a consistent measure of need, pretty finely grained distinctions between one level of need and another, literally dozens of individual categories of need across the spectrum, and then that payment relates to that full spectrum of need, the continuum of services, the continuum of need, the continuum of services, the continuum of payment. Payment mechanisms should reward both efficiency and quality. That's the policy target. It's now we're now turning to the mathematical challenge of making that happen. Finally, performance should be measured in such a way that each provider has the opportunity to succeed. And this is a principle, actually, in many ways, all of these principles can be translated into mirror images across the payment improvement spectrum: medical care, developmental disabilities, behavioral health, long-term service and support, patient-centered medical home. Same principles apply. Performance should be measured in such a way that each provider has the opportunity to succeed. The thresholds won't be chosen arbitrarily. We're not looking to disqualify. Some of them may be harder to achieve than others. When that's the case, we are also committed to providing some sort of policy, either policy-driven or provider-driven solution to help providers get there, or allow them that opportunity. So there are two elements of payment related to these design principles that we want to discuss today. First is case mix. The second is the quality incentive. So what you see on the right-hand side is a depiction of 100% of the payment that a provider would get for a long-term service and support. Now, that bar is a lot higher for some services and types of services than others, institutional, non-institutional, etc. But this, just imagine if you're a provider that this is the total payment that you get for an individual. Case mix ties to a portion of payment to client acuity. So it's helpful to understand here that depending, and this could differ substantially based on whether the payment is to an institution or not, there will be portions of the payment for some providers that do not relate to the mixture of needs of their clients, the case mix of their clients. For facilities, for nursing facilities, think of the portion that is related to the mixture of need of their patients as comprising about 2/3 of the payment to that facility. Not 100%, but about 2/3. And you can see that next portion, which is not related to the case mix. Think of some administrative, capital, costs, that sort of thing. And then, and in fact, there's some judgment that's required. The judgment as to what portions of the payment are and are not related to case mix, that'll be part of the policy recommendation or opportunity or option that we bring for review. This service is, this portion of payment is not related to is not related to case mix. Brant may provide an example of that as he goes through his explanation. And then a component that we have added through this work group process based on feedback and actually in many cases specific recommendations from stakeholders is to add a component of the total payment that is specifically related to performance and quality. And we'll get back to those recommendations at the end of this work group. So just to fix in your mind as we walk through this process that when we refer to case mix, again, this may vary depending on the type of provider, but in particular for institutional providers, not all of the payment will relate to the mixture of need of your clients. There'll be at least a significant minority of that payment that does not.
In the quality portion of your bar there, who is going to make that determination, and how much will the facility have to do to provide the information for that and that sort of thing?
So in fact, that is part of the last few slides, and we'll get back to that today, to go sort of item by item for the quality metrics that we're currently focused on for long-term service and supports, for the nursing facility payment anyway, what those metrics are and where the data comes from. The decision about how big that piece of the payment should be on average will be part of the sort of whole methodology that we bring through the regulatory process as a package.
The items that would be in the list that are not part of the case mix, have those items been decided yet?
They have not been decided. And when we get to the sort of calibration and numeric phase of this, that's one of the decision points that we will bring to this group also for review.
Okay.
So I think Brant provided an example at the tutorial that he and Mary hosted a few weeks ago. Cleaning, food services, etc. Do those relate to the level of need of the client? Do we vary that portion of the payment in an institutional setting for food, for cleaning, and for related services? Yes.
So again, what are the quality measures used for the home-based services?
Do we have recommendations? We don't have a set of recommended metrics yet, but we will need input on that. I certainly encourage that input. It would be a good time at the end of this presentation when we talk about metrics to bring those up, and we'll be addressing a package of HCBS performance metrics in a future work group.
Will they be coming out at the same time as the nursing homes?
Yeah, so the timeline essentially is synchronized, and we're working, more than a year out to when all of those would begin taking effect. Now, let me add to that answer the following. If we find and are told and agree and mutually decide that there are some changes, either in payment or eligibility or quality metrics or what have you, that are so profound that we want to avoid, a damaging and too abrupt implementation, it could be that there are phases of implementation. So what I want to point to is that July 1st of 2014 is when implementation would occur. It may be that it is also phased.
Hi, I'm Brant Freese from the University of Michigan, and with me is Mary James, also from the University of Michigan. We were asked to go through some examples and description of what case mix is and how it was measured and how you move from there to payment. We'll do this at a fairly general level, but of course if there are specifically more detailed questions, we're glad to answer them when we know them. Some of this, as Andy has described, some of these things will be developed over time in terms of exactly how they'll be implemented. So let me start at a very basic level to talk about what case mix is. It's a relative measure of the cost of caring for an individual person. And so it says this person costs 20% more to care for than that person. And therefore, you can then accumulate it to some group of people. It could be everybody in a nursing home, or everybody in the eastern part of the state, or everybody in a home cared for by a home care agency. And that measure then can be used, if I could have the next slide, could be used for a variety of purposes. So the one that everyone focuses on, and the one we're talking about here, is payment. But I always like to have some conversation about the fact that there are lots of other uses of case mix that I hope you'll think about. They're very useful for comparing facilities or agencies to understand, are you caring for heavier care people than other people? Who are you caring for management purposes? For example, has your case mix changed over time? You are seeking heavier care people. You're actually getting heavier care people than you had last time, because that your staff may be, say, complaining that their case mix is very heavy, they don't have enough time to care for people, and it may or may not be the case that, in fact, your case mix has changed since the previous time. And then also it's very useful, in fact, for measuring outcomes, that many of the outcomes that you want to measure will be associated with risk scores of risk of people having particular problems, and very often an adjuster that you might want to make to level the playing field, to make sure that facilities that care for very heavy care people don't have different measures, don't get this, you adjust the measures of quality for the differences in the patient population. Case mix is a very useful measure in doing that. But having said all of that, I know that the majority of people sitting there are going to be interested mainly in payment use, and we're going to be focusing for the rest of the talk on the payment issues. Next slide, please. So why do we want to use case mix for nursing facility payment? And I think this is sort of a no-brainer to some extent. It follows, the money follows the person type of principle that facilities that care for heavier care people should get more payment. That allows them to provide the appropriate amount of care to individuals. They don't get it. If facilities are not paid sufficiently for care of heavier care individuals, they can't be expected to provide appropriate care. And that payment can't be indirectly determined. An example of that would be a facility that takes a heavier care population, and then next year, it'll be until next year before that population then increases their costs, which are then built into next year's rate. It doesn't make sense to do it indirectly. It should be the case that if you care for a heavy care person, you admit a heavy care person, then the amount of money that you get for that person, or the overall amount of money you get for all of your people, should go up proportionately to recognize that that person will take more resources within the facility and that the payment will be allowed. Another way to think about this is that whatever amount of money the state provides, think of that as a pie. Whatever the total pie of payment is, those facilities that care for the heaviest care people should get a larger portion of that pie. Now, everybody may be underpaid, everybody may be overpaid, but at least the situation will be that the lion's share of that money should go for people who are caring for heavy care people as opposed to people who are caring for light care people. Why do you use case mix payment nursing facility? That's the principal reason. Now, why you, at the same time you do it, there may be other payment reforms you want to do. Pay the way you pay for other costs. At the same time, you may want to revise. So in Andy's example, where you had the 3 bars and you said case mix is going to affect the case mix portion of the payment, here you're also looking at thinking about, for example, changing the way you pay for other fixed costs, or the way that you're potentially now thinking about paying for quality improvement. Next slide, please. So some of the other advantages of case mix payment, this is one where you guys should be very interested in, and that is that right now, if we talk about the size of that pie, the size of the pie is essentially fixed every year by your legislature, and maybe you'll get an annual increase of some percentage in it. But what happens if facilities actually are taking much heavier care people because of the incentives of a payment system, for example, to allow it, at least get rid of the disincentive to care for the current incentive to care for light care people by being paid on the average for a very light care person. If overall case mix in the state goes up, then automatically you will be receiving more money because it'll be built into the payment system that you're going to be accessing higher payment rates for those individuals. So the actual size of the pie will automatically adjust upward. It'll be bigger, and that's something that you don't have to go back to the legislature to get extra money for. You don't have to argue with anybody. It'll be built into the system to allow for overall case mix change. It's something that I think is a good thing, and it's an appropriate thing that it actually would work that way. Such systems that have case mix payment also improve access for heavy care people. Any facility that takes a very heavy care person, when they know that they're going to be paid on the average for an average care person, it's a lost leader to some extent. And therefore, it discourages taking heavy care people who very often are backed up in hospitals or elsewhere. And so we think it's really good to have that type of incentive in place to improve access.